What's up, you guys? Welcome back to my channel. If you are new here, welcome. My name is Margaret. I'm a labor and delivery nurse. I'm about 2 weeks away from being off orientation, and I thought it would be fun to do a typical day as a labor and delivery nurse. I think that it goes without saying that there isn't really a typical day in labor and delivery. Every day is different, which is part of the reason I love this specialty so much. You will never get bored and you just never know what you're gonna come into. But today, for the purpose of this video, I made up a day that would kind of incorporate almost everything that we do, at least on a regular basis. Of course, there are things that come up and every single patient is different and their needs are different, but I just wanted to give a good representation of what it's like to be a labor and delivery nurse. So if you like this video, please give it a thumbs up and don't forget to subscribe so you never miss a video. Let's get into it. I wish I could have filmed more in the hospital, but the reason this is kind of a sit-down video instead of a vlog style is because we have rules against filming in the hospital. I don't like to push the limits on that. I would hate to even accidentally violate any patient privacy, and I'm hesitant to give too much information away about the hospital I work at just for safety purposes. So I'm sorry that I couldn't actually film too much while I was in the hospital. Starting off the day, I arrive at the hospital around 6:45. I clock in, I grab my scrubs. Because we sometimes have to go to the OR, we don't wear scrubs to work. We are issued scrubs when we get there. So I go to a big machine, swipe in, put my sizes in, and then it's like a vending machine for scrubs. It spits out my scrubs for the day. And then I'll go change in our locker room, and then I will head to the unit for Huddle. 7 o'clock, we sit for Huddle. That's basically where the PFC for the day, the nurse in charge, comes and tells us what kind of cases we're looking at, how many inductions there are, how many scheduled sections there are, if there's any special patients on the unit that need special attention, and basically sets the tone for the day, lets us know who's in charge and what we'll be dealing with that day and how busy we are. At 7:15 after Huddle, I will go to my station and get report from the nurse from that night. We do bedside shift report, so I'll go into each of my patients' room. We're 2-to-1 ratio, so that means I get 2 patients. So we'll go into our patient's room, we'll go over report, I will meet my patients, say hi, ask if there's anything they need to tell me, any important information for their birth plan, I will ask them about then. And if I have a minute, I'll kind of go into their chart, spend a second writing down important notes if they have any antibiotics due or any other important medications that I'm going to need to get started on or I have to do on a routine basis. I always carry, at the team stations, we have little note cards, so I always carry 2 in my pocket at least, 1 for each patient, just to have a little cheat sheet as to when I need to do everything for the day. I have to refer to my notes, it's a busy day. At 7:30, I will start notes on my patients. So notes are what we call charting on their tracing. So every patient, for the most part, is hooked up to monitors for fetal heart rate and contractions. And every 30 minutes, we review the tracing and we do a note or we document on that tracing. We'll do that every 30 minutes up until active labor delivery, where we'll chart every 15 minutes. At this time, I'll do anything that I need for my patients, get them anything that they need. This is also a good time where the doctors are coming around, where we will do a cervical check if it's been a while or if our patients want them. It's up to them, but it's a good time to do a check after, couple hours that they've been laboring during the night. Another part of my morning checks, or if I were to get a new patient, is checking the room. So I go around the room, I check that we have all the equipment that we need, all the emergency equipment, make sure there's a stool in the room, and check the baby bed. So we have these Panda baby beds, and I check that the suction is on, that it's hooked up to oxygen, that we have a cord clamp, a bulb syringe, a hat, a diaper. All the blankets are set out, and the towels for drying and stimming are on the edges, and that we do every time there's a new admission and during every shift. So at the beginning of my shift, when I meet my patients, or slightly after, I will go through and make sure that equipment is set up. I'll also make sure that any type of neonatal resuscitation equipment is available and in all sizes in the room in case there were to be an emergency. Around 8:30, this is a really rough time, but in my made-up day around 8:30, I will eat breakfast. Really, meal times are whenever I can fit them in. If it's a kind of a steady day, I'm not coming in and delivering a baby right away, I usually have time to eat breakfast around 8:30, 9:30, somewhere in that. This is when things there are no times to assign. This is just other things that happen during the shift whenever they happen. Let's pretend our patient is ready to push. They are 9 centimeters dilated, 100% effaced, and the baby's low enough that it's time to go. If the baby's super low, which is called their station, the doctor will most likely stay in the room and we'll all deliver this baby together because there really isn't time for them to leave and come back. If we think that mom might be pushing for a while, I will push with my patient until it's about time to deliver that baby. I'll give my doctor and my charge nurse a call, and they'll come in and we'll all finish out the delivery as a team. We are ready to push. The patient calls out, she's ready. I will call the doctor. I will call my charge nurse. Once the doctor's ready and dressed and in place, I will break down the bed. We open the delivery packs. We have 2. They're both sterile packs that we open on basically a table that we've already set up. Once that's all set, the doctor's dressed, patient's in position, we're ready for our final pushes. You know, myself and my charge nurse and the doctor will be coaching the patient on their pushes. We push, the baby's born. It's my job to take the baby and place it on mom's chest. We'll wait for delayed cord clamping. We delay till 60 seconds, as long as everything is okay. Big disclaimer here, like, things can happen in any delivery and you have to be ready for that. What I'm describing now is a kind of a classic, nothing's going wrong, everybody's healthy, mom is good, baby's good, so these things can happen. In an emergency, you might need to make different decisions. But baby's on mom's chest, we've waited a minute for the cord to stop pulsating, and the doctor will have the partner cut the cord if they choose. Generally, while this is happening, I am stimulating the baby and suctioning if needed. Once the cord is cut, we'll actually get into our final position for skin to skin. So our gowns have buttons on them, so I'll help mom unbutton her gown and pull it down and place that baby for skin to skin, where they'll remain for, we love if they can stay there for an hour. Of course, this is up to the mom. If she wants us to take the baby, dry them off and clean them off and bundle them up, then we'll do that. But a lot of our moms really love doing skin to skin, and there's so many great benefits if you take advantage of that. What they call is the golden hour right after delivery. So I really love it when I can kind of leave that baby with mom for as long as possible and as long as everyone's looking happy and healthy. So I'll place the baby up for skin to skin, and that's when I start my documentation. When I know the baby's safe, on mom, being held on to, everything's taken care of in that aspect, I'll go over to the computer, I'm right there, and I start my documentation. I need to chart the delivery record, and we need to start postpartum meds at my hospital. It's standard that we run Pitocin postpartum. This helps with the uterus clamping back down and prevents hemorrhage. We need to confirm baby bands and put the bands on mom and baby if cord blood needs to be sent. Usually our charge nurse does that. She's also still in the room helping with all these kind of post-delivery tasks. It's honestly chaos when I first started because I didn't really know what to do. I kept finding myself in delivery being with my preceptor, and then as soon as the baby was born, I like froze and would just step back. So it took me a little while to actually get involved in the post delivery activity. So while all this is happening, baby's on mom, I'm doing the delivery record and the newborn charting. We're drawing cord blood and sending the placenta. Meanwhile, the doctor is sometimes still suturing if there is a tear and basically finalizing the delivery with the patient. I would be helping the doctor with any additional sutures that they might need. If we need extra meds for bleeding, I'll go get those. And all while I'm doing this, I'm checking on mom and baby. So mom and baby are my first priority. It's kind of something I've had to learn to just keep my eyes on the baby every, few minutes, just looking over, making sure they're still looking good, still looking happy and healthy. Once the doctor is finished, we will put the bed back together. So our beds, I kind of skipped over this at the beginning, but when I say break down the beds, I mean the bottom of the bed literally comes off and mom puts her feet in stirrup. And I will say not all babies are delivered this way. Some doctors prefer not to have the bed broken down and feet in stirrups. Some of our moms, especially if they're going natural, need to be in different positions. They don't like to be on their back. I've had babies born mom on all fours or kind of with her arms over the bed and like kneeling. This doesn't always happen, but I'm going through kind of a standard delivery, I guess. So if the bed was broken down, we'll put it back together, get a fresh pad underneath mom, put her, feet off the stirrups back into bed, get a warm blanket and any ice packs or like peri pads that they might need. And basically just kind of do the first round of cleaning up and getting mom comfortable after delivery. This is also when our belly pushes start. After delivery, every 15 minutes, for the first 2 hours, we push on mom's belly. This is really to feel the fundus, which is the top of the uterus, to feel that it's getting firm and it's lowering in the belly. Basically, that it's shrinking back down. Let's say that it's not. It's not firm, it's what we call boggy, and it's kind of rising in the stomach. One cause of that could be that her bladder's full. That could keep the uterus from clamping down. Another could be hemorrhage or excess blood or a clot or retained placenta. So that's the stuff we really want to avoid. Every 15 minutes we'll do that and we'll chart on that. Every 30 minutes we do a set of baby vitals for the first 2 hours. So it's 4 sets of baby vitals and 9 belly pushes over the course of recovery. And of course we'll chart on that all along the way. So I leave the baby where they are, do their vitals, do a belly push, chart, and then when we come to the end of the 2 hours, everything is done. Clean up mom, take down her meds if they're done, get her a new gown, get baby in a little shirt, let her go to the bathroom, give her some soapy washcloths and warm water, a fresh we have this kind of mesh underwear and a pad, just help her feel a little bit, kind of the first step towards being put back together kind of and feeling clean and, more like herself. Once she's all ready, I call up to the mother-baby unit. We all go together, we transfer, I give bedside report, congratulate mom and her partner, and head back down to do it all over again. At the end of the day, around 7:15, the nurses come in for the night and we give report and head out. So that is an example of a day as a labor and delivery nurse. I feel like there are so many other things I could have mentioned. It just doesn't really even begin to cover all the variations of labor. I just don't think I could ever make a video that could, but I hope it gives you a good representation of what I do on a day-to-day basis and what it looks like to be a labor and delivery nurse. If you have any questions at all about nursing, L&D, anything, leave them in the comments below. I hope you found this video helpful. If you liked it, please give it a thumbs up and don't forget to subscribe, and I will see you in the next one.